Thank you to those listening. Again, my name is Christina Sire. I'm with the Iowa Medical Society, and I'm excited to introduce our speaker today for talking about toxicology challenges from the Iowa Poison Control Center. Today, we have Dr. Joshua Trebach, who's joining us to provide his subject matter expertise relating to this topic. He is a medical toxicologist and emergency physician at the University of Iowa Hospitals and Clinics. He's also a clinical assistant professor of emergency medicine and is the associate medical director at the Iowa Poison Control Center. Dr. Trebach received his medical degree from the Johns Hopkins University School of Medicine and completed his residency in emergency medicine at Johns Hopkins Hospital. Dr. Trebach completed his medical toxicology fellowship training at New York University in New York City Poison Control Center, and his interests include medical education, if that isn't obvious, public health, clinical research, disaster preparedness, plants, mushrooms, and everything that involves toxicology. So again, very excited to have him join us today, and I'm going to let Dr. Trebach take the floor.
Thank you very much for that introduction. Let me go ahead and share my screen here. Um, all right. Should be seeing my screen A-okay. Let me move the chat so I can see that too. Perfect. Alrighty. I'm glad to be here. Thank you for that introduction. Again, I'm Josh Trebach, one of the emergency docs and toxicologists at the University of Iowa. But my role I'm speaking to you on behalf of today is the associate medical director of the Iowa Poison Control Center. So really, really happy to be here. And I'm going to chat with you all about different trends and toxins to be aware of that we've seen not just this year, but kind of in the past couple of years. Now, obviously, this isn't going to be a all-encompassing of all toxicology that ever existed. Uh, I would love to do that, but I am told I cannot go longer than an hour, and I know other people have things to get back to today. So I will start off by saying I have no financial conflicts or disclosures. And here's some of our learning objectives. We are going to talk about substances of increasing concern based on recent trends in tox. We are going to discuss new and evolving information we have with respect to specific poisons, and then talk about ways we can utilize different resources to assist us in the management of poisoned patients. So I'll start off by saying, normally if I'm talking to a group of people, I ask you to raise your hands if you've ever called or contacted a poison control center. And sometimes it's everyone in the room, and sometimes it's only a couple hands. So I always want to put this here. Our poison help number, this is routed to your nearest poison center, similar to how 911 is routed. So this 1-800-222-1222 number is our standard number for all poison control centers. Again, it'll route you based off of I guess where you're calling from, which cell towers it's going to, etc. But this is the number you can add to your smartphone. This is a QR code that'll, if you, I know it works on iPhone at least, where it'll help basically add you or add the Poison Center as a contact. So go ahead and do that if you have not already. I like to remind people that the Poison Center is not just a place for people to call if your child licks a mushroom outside. Although certainly we do take those calls. We actually get calls from all over the state from not just parents or nurses or physicians or NPs or PAs. It's basically everyone you can think of can call the Poison Center. So our statewide Poison Center was established in 2000, and common question that people sometimes ask is like, who answers the phones when I call the Poison Center? Well, they are our pharmacists and or our nurses who are trained to be specialists in poison information or specialists in poison information, or SPI. We call them our spies. Sometimes once they do the certification, they'll become certified spies or C-spies. So it sounds pretty cool when we can say like, hey, our spies told us this information. So we communicate with them directly. Now, there is a medical toxicologist such as myself or our medical director, Dr. Dan McCabe, or some of our other colleagues who are available 24/7 for any sort of cases that are complex or require a higher level of management or just really tricky, or if there's expertise that's needed. So our Poison Center specialists know how to get in touch with the toxicologist, and again, available 24/7. We have over 20,000 cases a year and over 50,000 follow-up calls a year. And again, I'd say like around two-thirds of these come from the public, but around a solid third come from healthcare providers. And again, this can be anywhere from an ER to an ICU to a outpatient doctor. So we take care of it all. Um, so one of the most common things we get called about for patients who have been poisoned or there's concern for a poisoning, either intentionally or unintentional, is uh, this little pill here, and this is Tylenol or acetaminophen or paracetamol. And question that sometimes comes up is why is acetaminophen so dangerous? This is like an over-the-counter medication. Is it even that big of a deal? Well, per our National Poison Center data, we know that acetaminophen is one of the substances associated with the largest number of fatalities. Um, not just because of how dangerous it can be in overdose, but also because of how readily available the drug can be. So, sure, we know that you can go out and just buy acetaminophen or Tylenol, but there's plenty of other things that have acetaminophen in it where it can kind of creep up on you, and you might end up taking more than you anticipated. Again, an unintentional exposure to too much acetaminophen, or if someone is purposefully ingesting medications or substances due to stress or an intent of self-harm. Readily available things in the household could include products like you see on the screen here, all of which contain acetaminophen, and there's plenty more that I haven't listed here. We have data in our world that actually acetaminophen is so common to overdose on that the classic teaching that we tell our trainees is that if you have a patient come in with a report of an intentional ingestion of a medication, we actually always want an acetaminophen level to be checked even when the patient doesn't report taking acetaminophen, just because it's so pervasive that we have data to support actually checking for acetaminophen even when it's not reported in cases of overdose. Um, Now, I mentioned that it's not just pervasive, but acetaminophen can also cause these like vague sort of symptoms. Okay, sometimes patients can actually be asymptomatic for the first 24 hours, uh, and sometimes patients' symptoms can be very kind of not that impressive. Like, ooh, maybe some nausea, maybe a little upset stomach, some vomiting, fatigue, malaise. And again, these are really non-specific symptoms that really don't scream this is a very unique thing for acetaminophen poisoning only. So sometimes these can be missed or even overlooked by clinicians. Now, the good news is, I know I just told you all the bad news. The good news is that we actually have an antidote for patients who are experiencing acetaminophen poisoning or toxicity. And it's an antidote called N-acetylcysteine or acetylcysteine. And this is a medication that, again, this is a very brief talk. So as much as I would love to, I love talking about acetaminophen, but you know, how much to give, what dosing to give, what dosing strategies to give, what do you do if there's delays in dosing, doing changes in modification of the dosing to do more, or changing how we're giving it to the patient, whether it's oral or IV acetylcysteine. These are all questions that the Poison Center can help answer. Okay, and I would venture a strong suspicion that I'd say that every single day we deal with patients who have been intentionally or unintentionally experiencing toxicity from acetaminophen. So every single day at the Iowa Poison Control Center. So pretty common. And again, we are always available to answer questions, anything about acetaminophen at any time. Okay. So that's my brief spiel on acetaminophen because I want to get into some other topics. If there are, I'll keep an eye on the chat as well if there's any questions. But please remember, I'm going to put my email at the end in case anyone has any questions they want to ask as well. I'm happy to take any questions as I see them come up. So please feel free to throw them in the chat if you got them. Okay. All right. So we love to be called. Don't forget, Poison Center loves to be called. All right. So next thing we're going to talk about is opioids. And I think everyone in this chat or in this virtual room here is familiar with the fact that we are in an opioid epidemic in this country. And It started out with prescription opioids, then moved to we're seeing more heroin, then fentanyl, and then fentanyl with stimulants. Okay, and these four categories actually describe these are described in the literature as being the different waves. Okay, so you can see this color coded screen here, but I'll read out the colors. Wave one is in green here, and that's this top line. Um, and this is the describing the rise in prescription opioids in the early 2000s. This second line here, oh, actually, let me pull up my laser. I realize y'all can't see that. So top line here, this is green, and this corresponds with this wave one. This second line here from the top is purple, and this is the second wave, which is the rise in heroin without stimulants that we saw in like 2010. You can kind of see that here. This third line, the blue line here, is wave three, which is the rise in fentanyl without stimulants. You can kind of see how that kind of has tracked up as the first two have gone down. And then lastly, this red line here is the rise in fentanyl with stimulants. Okay. So we're seeing both the fentanyl without and with stimulants kind of take that rise. And so these four waves are what we classically described as these waves of opioid overdose deaths, which you can see right here, deaths per 100,000. Um, this is what we've used to kind of describe these waves. Things are always changing though, and I'm not saying we're suddenly not dealing with opioids being a problem, but I've actually had a lot more recent questions, I'd say, in the past years or months to years, not about opioids specifically, because I feel like a lot of our clinicians that I interact with feel pretty comfortable managing patients who have been opioid poisoned or opioid toxic, but instead I'm getting questions about this. Okay. One question I get, is it kratom or kratom? Honestly, the jury's out on that one. We don't have we don't have a randomized control trial saying what's the preferred way to pronounce this, so I might change it up as I'm talking. But kratom or kratom, that's something that we've been seeing a lot of, and I'm getting a lot of questions from not just patients but also clinicians as well. So let's talk about kratom or kratom. So, kratom refers to the leaves that come from this plant, Mitragyna speciosa. And this plant contains the leaves contain over 40 different alkaloids. Okay, these alkaloids can interact with the body and different receptors to cause different effects. Now, opposed to listing off all of them, there's really two big important ones that are worth paying attention to. The first one is on the left here. You can appreciate its structure if that appeals to you, or you can choose to block that out. But this is mitragynine, okay? And this is the most abundant alkaloid in kratom, is mitragynine. And mitragynine is interesting because it's a partial agonist at the mu-opioid receptor, so it can cause some opioid-like effects. However, mitragynine also has some alpha 1 agonism and some alpha 2 antagonism. What that translates into is that actually can create a pro-adrenergic like effect. So people can actually sometimes get effects that look like they're adrenergic, things like wakefulness or tachycardia, hypertension, like a stimulant like effects that sometimes people can experience. And we'll talk about that in a little bit. Now, 7-hydroxymitragynine on the right side here, sometimes abbreviated as just 7-OH. So you may see products sold in smoke shops and things like that that say 7-OH. 7-hydroxymitragynine also exists in kratom, but to a much smaller degree. And so 7-hydroxymitragynine is actually also a partial agonist at the mu-opioid receptor, but it exhibits greater binding for the mu-opioid receptor than mitragynine does. So in a way, you could think about it as it's almost the 7-hydroxymitragynine is more likely to cause opioid-like effects, whereas mitragynine may create sort of sometimes a biphasic response or a wakefulness stimulant sort of response. Okay. Um, Now, there is some emerging studies suggesting mitragynine may have some ability to affect serotonin receptors as well, but that's a topic for future discussion. But so the big deal is these two main things, mitragynine and 7-hydroxymitragynine. Now, kratom comes in all these different formulations, okay? There's this like dried leaf powder here. There's capsules. There's tablets. Sometimes the tablets come like pre-cut up into like fourths. There's tea. There's black cherry gummies I found on the internet. There's these like liquid shots. There's vape products. There's all over. It's all over. Um, Now, the question you can ask is, okay, like let's take this kratom tablet here. How much? It says 300 milligrams total alkaloids. I don't necessarily know what that means. Is that how much of that is what I just showed you on the previous slide? How much of that is mitragynine? How much of that is 7-hydroxymitragynine? Is this going to give someone opioid-like symptoms? Is this going to be helpful for wakefulness? Some of these products people purposely pull out or concentrate that 7-hydroxymitragynine and purposely just sell 7-hydroxymitragynine. Uh, so sometimes people aren't aware that there's even a difference between mitragynine and 7-hydroxymitragynine, or that kratom refers to both of them. So I've seen this be super variable. And what's tough is that looking at all of these products, we really don't know how much of anything or what specifically is in any of these. Okay, I know that's a little scary to think about, but this is a product that people can buy, without in the state of Iowa, without a prescription, and you just go on in and you say, hey, I'm going to purchase this product, but we really don't know what's in it. Okay, so these aren't FDA regulated products, the same way that like you think about an antibiotic or a patient's atorvastatin or something being FDA regulated. So we really don't know how much is in these, what else is in these, what's not in these. There's limited quality assurance and there's product variation. And we've seen cases where some of these kratom products actually contain synthetic byproducts or things that weren't even intended or disclosed to be in there. Okay. Someone could take the same dose of this kratom product here and then buy this brand and take the same dose and have wildly different effects. Okay. In some cases, even buying the same product from two different locations or even the same location might give you different effects because, again, there's no quality control. These aren't really regulated. An example I usually give our my colleagues and our trainees is that if you were to take in a torvastatin or a antibiotic from you get from the pharmacy, on the western side of town, and then you next month fill your prescription from the eastern side of town, they should be the same, right? These are FDA regulated products. You're getting the same. If the dose is, 20 milligrams for a certain pill you're taking, it should be 20 milligrams in both. That's not the case for these products where they're unregulated. So we really don't know that like how much of these are in each of them. Okay, so it's a little bit concerning.
Dr.
So
Trebach, we do have a
yeah,
question.
yes.
Are there any oh my gosh, I'm gonna mess up the name.
Oh, I see it.
Ophthalmic
Yes.
manifestations that have been reported with kratom use?
That's a good question. So yes, are there any ophthalmological manifestations that have been reported with kratom use? I don't think about those classically. I think sometimes people can have like changes in their pupils depending on which effects are predominating. But like that being a classic chronic symptom that I think of, not off the top of my head, but that would be neat to see if there's reports of people who have chronically been using kratom report any sort of ocular concerns, but not that I've personally seen, but it's worth perhaps a dive into the literature to see what we can find. So great question. Um, again, this is not a controlled substance. Uh, Kratom is illegal to market as a dietary supplement or a medical treatment or a food additive, and it kind of exists in this gray area as a unapproved new dietary ingredient. I'm doing quotes. There's varying legality in different states. In Iowa, there's legislation that's been introduced, but I believe has been put on quote unfinished business in the category of unfinished business right now, um, in the move towards classifying it as a controlled substance. So hasn't really moved forward with anything like that yet. So I'm going to show you some data from some different papers. Here, this This table comes from a publication where over 300 people who use kratom were asked for their motivations for use and why they use it. And again, I'm not going to read off all of these, but you can see like the top was people say they just want to feel less crappy. Some people say it's safer than other substances or treating symptoms of depression and anxiety. Um, some people are just taking it to relieve withdrawal. All sorts of symptoms here. Okay. I think we, sometimes I think patients who use kratom sometimes get there's a stigma, of course, with product using any sort of substance. It seems that you are, quote, you suddenly become a quote drug user and therefore are using drugs for bad reasons. But not these reasons like here aren't unreasonable, right? I mean, like if someone's like, "Hey, I need to have some energy for work," right? Like people take energy drinks. I mean, like if someone's like, "Hey, I'm trying to treat my symptoms because I can't see my doctor won't help me get the drugs that I need," or I'm going through withdrawal. I mean, like these aren't not everyone is doing this just for recreation, fun, and relaxation, right? Certainly there are some people who are, but again, I think this highlights a need and a gap we can help address from a public health perspective opposed to something we can use to like uh, stigmatize or criminalize people. This table here is another comes from another study that said, hey, like ask respondents why you used uh, kratom, and this was you can see here people were reporting, they also looked for people who were reporting whether they were using it for opioid reduction or not, but you can see kind of the effects here, right? Like anxiety, depression, PT, post-traumatic stress disorder, treatment of pain, some people just trying to use it to stop using prescription or illicit opioids. Um, so what I kind of just highlighted with kratom is that so it's kind of this mix of like depending on what the cocktail you get of the alkaloids, right? Whether it's a lot of 7-hydroxy or it's mostly mitragynine, you're getting this combination of like maybe some opioid-like effects and maybe some adrenergic effects and possibly some serotonin effects. Okay. So people can have all sorts of symptoms. Like our colleague had just asked us about ocular symptoms. Yeah, you can have big pupils, you can have small pupils. It kind of depends on what we're seeing present. I'm not going to read off all the things here, but just know that there's also drug-drug interactions. Sometimes you could expect a synergistic or additive effects with other medications. And there's actually data to suggest that under gastric conditions, there's another metabolite that can form that could be an oxidative metabolite that could actually be a little bit dangerous, but that's again, so further study is still needed. But we see patients having any of these symptoms, and it's not always predictable. So how do we manage patients who are toxic from kratom? Well, we're managing sort of any seizures or agitation with benzodiazepines. Uh, it would be reasonable to give these patients naloxone if we're worried about respiratory depression or ventilatory insufficiency. So the same way if you were going to give a patient who you're concerned was exposed to an opioid naloxone, similar sort of pathway of thought here. And then it's good supportive measures for these patients. Again, we don't have an anti-kratom antibodies that we give patients or some magic antidote that suddenly sucks up all the kratom, unfortunately. Okay. The diagnosis, this is a question that comes up. It's largely based off the history and the physical, right? Standard urine drug screens really don't detect kratom. And if you do want to test for kratom, you're usually doing send out testing. So it's not something that's going to really happen in real time. Now, on the flip side, I just told you all about kratom and the toxicity we can see from it. On the flip side, people can actually withdraw from kratom as well. Okay, so the same way if someone is their body is exposed to opioids for an extended period of time, and then they stop and go into opioid withdrawal. Kratom, which also has some opioid-like effects, as I mentioned, with that partial agonism at the mu opioid receptor, these patients can actually experience opioid withdrawal. And so I've seen patients who have, I've seen them personally and also been consulted via the Poison Center about patients who have been experiencing what sounds exactly like opioid withdrawal. People are having muscle aches, insomnia, rhinorrhea, piloerection, yawning, restlessness, etc. And the way we treat these patients is actually the same way we treat patients where we're worried about withdrawal from opioids, and is that's by giving patients who we deem to be in withdrawal and sort of pass our like checks about when they last used what substances. We treat those patients with buprenorphine, naloxone, or Suboxone. There's other therapies that exist, like adjunct therapies, like you can give medications to help with muscle spasms or diarrhea, but buprenorphine naloxone has started to get a lot of attention to treat patients withdrawing from kratom. Now, I'm going to show you on some slides here. This is a very summarized version, and it should not take the place of your hospital's protocol if you do have one for initiating buprenorphine naloxone, or if you have some sort of special pathway through your pharmacy team or whatnot. But in general, and again, this is a summary, not served to like be a sole source of like how to initiate this in the ER. What we teach our trainees and our clinicians is that you always want to determine the patient's last use of an opioid, because just because someone uses kratom doesn't mean they don't aren't also exposed to other opioids. And the reason for this is because we actually will wait a certain amount of time depending on if it's heroin or an extended release oral opioid or fentanyl or methadone, other things kind of. We wait a certain amount of hours before we even want to give buprenorphine naloxone, because we don't want to lead to precipitated withdrawal. Okay, we don't want to send a patient into withdrawal by giving them buprenorphine naloxone. Okay, so there are some standard historical questions we ask about that. And again, if there's any questions about that, you can always call the Poison Center. We're happy to talk to you about this. Uh, Patient should have a COWS score of greater than or equal to 8, and I'll show you what the COWS score is on the next slide. It's uh, a scale that we can use to help measure in how much withdrawal someone is in. Okay, actually, I'll go to that now. So this is an example. This is from MD Calc, where you kind of go through. You can calculate the COWS score. Obviously, I didn't fit the whole thing on the screen here, but you go through based off the patient's symptoms and heart rate, etc. You get a score. Okay. If the patient's COW score is greater than or equal to 8, and they meet the criteria for you're like, hey, it's actually at this point in time, I feel safe starting buprenorphine naloxone based on when they last used an opioid, or what opioids they'd recently used. Start with the 4 to 8 milligrams of sublingual buprenorphine naloxone. Recheck that COW score, and then redose depending on how the patient's doing. Okay. Um, I have talked to clinicians who work in ERs where this is extremely common, and many clinicians feel extremely comfortable doing this. I've also seen the exact opposite where no one feels comfortable doing this, or there's just questions about buprenorphine, or people are unclear how to dose it or what the side effects are or what they should counsel patients on. And again, that's what the toxicologists and Poison Control Center, addiction medicine colleagues, we all are happy to help y'all with this, okay? So if there's any questions, please let us know. Again, you can always call the Poison Center. And the goal is to hopefully discharge the patient, or when they do get discharged, you send them out on the appropriate amount of buprenorphine naloxone and have them follow up appropriately, either in an addiction medicine clinic or with a clinician who's comfortable assessing this and continuing to prescribe it, okay? And I've personally taken care of patients who have had really good response um, from the buprenorphine naloxone. Okay. I also tend to give these patients a prescription for naloxone nasal spray as well, just to make sure that they have that and instruct them on the use. Ideally, if there's a family member or a friend there as well, instruct them as well, just in case there were ever to be a concern. Right. Oof. Okay, so that was like my whirlwind through uh, kratom. Questions that I can help answer on kratom right now. Again, we talked about mitragynine, 7-hydroxymitragynine, some of the different effects, kratom toxicity, kratom withdrawal, and kind of how kratom from one source to another is not necessarily created equal, and so it's quite variable, and it's always a little bit of a gamble depending on what product you're getting where. Okay. So next we are going to talk about something else that's come up a decent more in the recent months to years or so. Something called nitazines. Okay. So nitazines are these very potent synthetic opioids. Okay, and these came around in like the 1950s in the context of pharmaceutical research, but started appearing in the sort of illicit drug market in like 2019. And these are like again synthetic opioids. They have this specific sort of like two benzyl benzimidazole structure that people can kind of just add side groups on to make new nitazines. So it's really hard to like track these down. So we have a gap in like data about nitazines, and I guess what we would call it is a surveillance gap. We have a surveillance gap. Well, I even wrote it on the slide. Great. We have a surveillance gap because it's hard to monitor for this because there's all these different nitazines out there, these different synthetic opioids that it's really hard to test for. It's hard to even diagnose or test because it can look like an opioid overdose or toxicity. And if someone does get exposed to it, there's lack of reporting, and then there's always new nitazines being made. So it's really, really challenging to kind of assess how big of an issue this is. Okay. Um, some people are very aware that they might be using a synthetic opioid that's a nitazine because they are purposely going after a certain one, and other people have no idea. Okay, so there is a bit of a gap here in our data. It's really hard to tell. Okay, so I just want to put a little thing out there for nitazines. Again, we still want to treat these patients with naloxone. Um, these nitazines are a DEA Schedule 1, but people are constantly creating new nitazines that can circumvent this. So unfortunately, the legislation can lag behind the creation of the new products, which is challenging. I didn't put the paper on here, but there was a study I found that showed that 62% of patients who use substances reported that they had consumed nitazines unknowingly used in products sold as other drugs. So again, it's really unclear how big of an issue this is. That was my brief spiel on nitazines. I feel like I always wanted to address it because it looks like that's not something that we comes up too often. I see a question in the chat. How well do nitazines get picked up on toxicology testing, such as through NMS? So, if you usually have to look for a specific nitazine, like we know certain Schedule 1 nitazines, like uh, isonitazine or etonazidazine. We know some of these exist, but if someone's made one that we don't have a test for yet, then that's not going to be even possible to look for, right? So it's only as good as what we have to look for it. But yeah, and then also those tests through NMS aren't going to be very time sensitive as well. Like your patient may have been fully recovered and discharged by the time the test comes back, like a week or two. I've like a week or two later, and personally, I've waited months for some testing to result. So it's tough, but it can be possible to test for these again, but it's not test possible to test for the ones we don't necessarily know about. Okay. And last but certainly not least, the THC and CBD products are something I definitely want to talk about because this is a thing that we are seeing not just I'd say across the country, and I definitely saw during my training on the East Coast, and I'm definitely seeing it here in Iowa as well. But so let's talk about these THC and CBD products. So first, a little bit of uh, nomenclature. So cannabis refers to the plant that the cannabinoids, which are the chemicals in the plant, come from. Okay, so cannabis plant, cannabinoids, chemicals in the cannabis plant that stimulate the cannabinoid receptors in the body. Um, the term marijuana is still sometimes used. It's a term that we have generally moved away from. It seems to historically has a bit of stigmatizing and racist context used to refer to different communities of color in the United States. We kind of just largely don't really want to use that term anymore. We kind of just stick with cannabis because that's the plant, and cannabinoids because those are the chemicals, and that's more straightforward. Um, there are many different types of cannabinoids. There's THC, there's CBD, there's Delta 9. This is a little typo here. This should be so Delta 9 and Delta 8 sometimes is confusing for people. Delta 9 tends to be the primary psychoactive component in cannabis. So when we say THC, we're usually talking about Delta 9 THC. Okay. Delta 8, again, this is a typo here. Delta 8 is a when you see products being sold as like Delta 8, people have purposefully taken uh, and modified that compound to be slightly different and cause some different effects. So I'll show you here. So Delta 9, you can see at the top here. We think about causing that euphoria and that sort of psychosis or hallucinatory effects that people sometimes describe when using THC. Delta 8 again does occur in cannabis, and it's thought to be a little bit less potent, but you can buy products that have been primarily made to just be Delta 8. But again, I want to reiterate, Delta, when we say THC, we're usually referring to Delta 9 THC. So my apologies for the typo on the last slide. There's other cannabinoids aside from Delta 9 THC and Delta 8 THC, though. There's cannabidiol or CBD. There's CBG as well. You can see the bottom of the screen here. So there's a lot of different cannabinoids out there. Um, and sometimes people don't really know what they're getting when they buy something, or they don't even know the different effects that it can cause. I've had a lot of patients tell me that they go on different places on social media to find this because the person selling it to them and their clinicians who they see don't know. So they're going to turn to things like social media, like Reddit and Facebook and all these other things to try and get information, TikTok, etc. So there do exist prescription THC and CBD containing medications, but similar to kratom, uh, over-the-counter substances that contain THC and CBD aren't FDA regulated and exist in this like again this gray area with limited safety and quality controls. So some places like here we can only have certain concentration of like THC and CBD products be sold for limited purposes here. Um, and so, again, not a lot of quality control that exists for this. And again, people can always travel to other places and purchase it. People can buy it off the internet. Um, Sometimes something can say, hey, we're legal because we have this amount, this many milligrams of THC, but in realistic or in real life, it's actually much higher than what they reported. So a lot of variation that we're seeing with these products. And this isn't like we're not saying, hey, this is a real big problem because everyone keeps, smoking a bunch of THC. It's actually these formulated products are designed to just look delicious, right? So you can maybe appreciate here. So this is Jolly Rancher gummies, sours, but in the top left it says medicated. Okay. Um, some of these are a little bit more on the nose, like instead of Sour Patch, you have Stony Patch. Uh, this looks like some Cheetos, just like a bag of Cheetos, right? And this is double stuff with one F, I guess. Stonios instead of Oreos. And then you can see medicated nerds rope here. The point is that you're like, oh, well, clearly it says it on the packaging. I think this is particularly a problem for many reasons. One is children. Okay, so as a former child and someone who still likes candy to this day, I do recall being able like going through my childhood home and like if there was candy and I found it, I would eat it without a doubt. And it doesn't matter where I found it, I would eat it. And so even if a child can't read or just appreciates this like bright these like little happy this happy apple and blueberry and watermelon that they have on here that looks inviting. A single like THC gummy can really be dangerous for a child, and we'll talk about that momentarily. Second is there's concern for people who don't read or speak English, right, with some of these products. So an example I like to give is that like if I were to travel to another country, I could recognize if there is like Coca-Cola or a McDonald's or something by the logo, right? but probably wouldn't be able to read other things that, if something's written in Japanese or something, I'm like, I can't really read that. So um, it would be tough to kind of get by if I'm concerned about these products. And I've had people who have been exposed to these products because they thought this was a candy. They found it in their child's room, or they saw this in the grocery store and were like, hey, this is on sale. So it can be quite a problem. So I mentioned this is particularly dangerous for children. That's because we see that in sometimes I've had patients or colleagues ask me, hey, like, what's the big deal about these products? Like, people get a little bit high and that's it, right? For the adult, they might have a sort of a quote bad trip. They might be like anxious or paranoid. But the doses sometimes in these products, keep in mind, are very, very concentrated. Like usually, like these products are like have a single gummy, right? Or if the ones I showed you here, sometimes people, will say just like have one gummy or have half of a gummy or have a 1/8 of a cookie. Like no one actually eats an eighth. Well, I don't want to speak for everybody. I personally would never eat 1/8 of a cookie. So like it's tough to expect people to have those doses if they don't know that what they're ingesting or what they're eating, especially if it looks like candy or food or chocolate. So uh, kids, especially, we've actually seen pediatric patients. We've seen an increase in exposures in pediatric patients for sure. Um, and the concern is that patients exposed to high amounts of these cannabinoids can actually, they don't just get a little bit loopy, sometimes they have dangerously low or dangerous changes in their heart rates, mental status. I've seen seizures. I've seen children needing breathing tubes and getting spinal taps and MRIs, all because, you know, this is potentially concerning if a kid starts having a seizure, right? You're going to work that up and having a several days to weeks long hospital stay, all because the child got into like a piece of candy, right? So it can be quite concerning. And as I mentioned with kratom, sometimes you really don't know what's in the product you're purchasing. So this was back in 2024 in the we saw this in Iowa, but also in several other states as well. There was a product that was sold in shops called Diamond Shrooms, and it was spelled with two U's and a Z at the end, which I dislike for other reasons, but uh, selling the Diamond Shrooms product. And this actually led to an outbreak where patients were having uh, symptoms like seizures and changes in heart rate. You can see all the states here that were reporting people being hospitalized and ill, and the jumping to it, this led to an FDA analysis, and it was found that these products, some of them contained all of these things which I've highlighted in green here, which were not intended to be in there. Or I can't speak as to why they were in there, but they certainly weren't disclosed, right? You have stuff like the bottom here, ibotenic acid and muscimol. That's from a poisonous mushroom. Okay, pregabalin's a prescription drug. Psilocin, Schedule 1, right? So I remember talking to someone, they were like, how can this be sold for people to just buy this? And I'm like, well, that's kind of the state we're at now with our limited regulation on some of these and poor quality control. So it's unfortunate that this even happened in the first place. There's also synthetic cannabinoids, which are lab-made chemicals that can be sprayed onto a medium that's usually like plant material or sold as a liquid, and they bind to the same chemical receptors as cannabinoids, but aren't natural cannabis compounds. So they can kind of cause the same or similar like effects, um, but as I mentioned with the nitazines, even if it's something Scheduled 1, people can always create new ones that bypass those regulations and therefore are able to get out of that. Okay, so definitely concerning. And again, do I expect the average person to know the difference between delta 9 versus delta H versus CBG versus CBD versus synthetic cannabinoids? No, right? Do I expect? I find that many clinicians don't even know the difference. So if a patient or an individual in our community has questions about this, they can't ask their doctor or their clinician, and they can't ask other reliable sources. They just turn to the internet and their friends. And I've seen people have unfortunate uh, effects from these products. Um, so a lot more to be done. So that was my quick whirlwind of things that we've seen. Of course, there's other things to talk about the role of like, gosh, like social media and TikTok trends and things like that. But we just have a limited window of time here, and I wanted to leave some time for questions at the end. So we can pause here and stop here for questions. This is my email. If anyone has any questions, they have that they either don't want to ask in front of a group of people, or you just think about it later and want to send me an email, please let me know. But it was a pleasure being here today. So thank you for having me.
Perfect. Thank you so much, Dr. Trebach. As you said, I will open the floor for any additional questions or curiosities. I personally had one, and this is going to showcase my taste in TV shows. I have watched The Pit, and maybe as an emergency medicine physician, you have thoughts on that. There is an episode where a child ingests a THC gummy, and that child became unresponsive. And I was curious on really the perception of TV and its accuracy relating to toxic exposures for that instance. And I'm not sure if you're like familiar
Sure,
with
sure,
that episode.
sure. I'd say that in general, it's wrong a lot of the time.
Mhm.
I don't think there's only a couple hundred of practicing toxicologists in the United States, and of those who do like consultation for uh, TV and television and movies and stuff like that, very limited probably, if any. So I personally I don't watch a lot of The Pit. I know of it, but like as an ER doctor, it's like my way of unwinding usually isn't watching other ER doctors be ER doctors. So I don't watch a ton of it. I did hear about that episode. But yeah, I mean, like, I do think, is it possible for a pediatric patient to go unresponsive after exposure to a THC gummy or something like that? Absolutely, and I've definitely seen that, right? Oftentimes the history is not even there that we have that. So an unresponsive child gets a very large workup, oftentimes invasive, depending on the testing that's being done. So certainly can have consequences. But as in media as a whole, um, there are many things that are misrepresented. Usually there's like, television shows or movies where they have some sort of poisoning or an antidote or something that they just get wrong. My partner has learned to not look at me whenever there's a discussion in in a TV show or media, like a movie about a poison or an antidote, because they know what my response is going to be. So it tends to not be that good. But if I'm always available for questions, though. I think it's interesting. I occasionally get like an author for a book reaching out, trying to talk about like how they can describe this in their novel or whatever like that. But yeah, so not too good, I'd say.
Thank you for that question. And we did just have one in the chat requesting you to briefly comment on xylazine, current presence in Iowa, and expected symptoms.
Sure. So, xylazine we think of as a alpha 2 adrenergic receptor agonist. We have seen it in illicit opioids, and sometimes this is also like a veterinary drug as well as like not really used in humans. Um, the symptoms we would expect would kind of be similar to what we would see from someone taking a large amount of like uh, clonidine. So sometimes you can see this initial hypertension, and then people can get hypotensive and bradycardic. Um, as currently, like what I always remind people that at the Poison Center we only have data on what is called into us. Okay, so it's possible that there's a lot more xylazine out there than we know of. We just aren't having it reported to us. And similar to with some of the products I mentioned, is that there's not like Usually there's not point of care testing that you can do. So even if a patient were to come in um, to the ED and then get treated and then discharged, usually that's not something that's going to be tested for a lot of the time. So I don't have the exact numbers of what's been reported in Iowa off the top of my head. I can always look into that. But the symptoms we would mainly see would be, again, CNS depression. People can get bradycardic, hypotensive. And there is some concern because if you were to combine xylazine either intentionally or unintentionally with other things that can be CNS depressants, you can lead to a much more synergistic effect. There's also concerns about the association with xylazine and different skin manifestations, different wounds, etc. Um, and the ulcers that can sometimes be associated with. So it kind of, again, the course of symptoms and the extent of symptoms do depend on the dose and how someone was exposed and other things that they're on. Um, so it's a little bit tough, but usually these patients can do well with good supportive care and especially focusing on the cardiovascular and ventilation of the patient.